So part of a psychosocial assessment, it's very important to understand, to review their diabetes history. And in our clinic, we do see women not only with gestational diabetes, but with type 1 and type 2 diabetes. And I like to know, for those women who have a pre-existing diagnosis, is how old were they when it happened, and what happened? How were you feeling? How did your family react to it? Who was inactive? Who took care of the diabetes, especially for our women who have type 1? Was this something that your parents did the majority of the management, and at what point did you take over? Do you have prior hospitalizations, complications associated with diabetes? What came of that? What was the outcome? What is your history of metabolic control? Have you had repeated diabetic ketoacidosis events, or have your blood sugars been fairly stable? What is your family's involvement? Are they involved at all? Is this something that you do strictly by yourself and they eat a different meal at the table? Prior pregnancy losses definitely are important to address, because this can lead, some women can suffer from post-traumatic stress from a prior pregnancy loss, and you may see a level of hypervigilance with these women, very stressed when their blood sugars are not within range. Does this mean my baby's going to die? I'm not feeling my baby move. Is something wrong? Not only is this affecting their ability to attend to the education from you, but can potentially elevate their blood sugars. So what is their current support system? Again, I can't reiterate this enough, that support, even though they have a lot, is it appropriate? Is it an appropriate match to their needs? And according to Dr. Cynthia Logston, a lack of match between support needed or desired and support received is particularly problematic. So what she's essentially saying is the stress they're having being adequately met by their support system, or is there not enough support there? General psychosocial status and history. Again, I'm looking at any history of mental illness, their support system, their coping skills, anything that's going to help them cope. Housing. Who cooks at home? How many people are in the home? We see a lot of blended families, or people who are staying with other people to afford rent. Is there adequate food for their diabetes meal plan? Education. Again, this is really important to understand how to best explain and educate to your patients what was their level of education, and so that you can basically be speaking at the level they need, that they're going to understand and comprehend. Employment status. Again, if they're able to come to appointments, is this causing a big stress at work because they have to come every couple of weeks? They have to call in their blood sugars. They have to stop to check their blood sugars. Work can definitely pose a big stress to diabetes self-care. Financial material resources. We know that that diabetes management can be expensive. We hope that our patients have adequate insurance to cover their test strips, their medication supplies. But we also know that healthy food choices, food higher in fiber, less high in fat, tend to be more expensive or more difficult to access, because they may not have the transportation to access it. Competing stressors. I want to know what else is going on in their life that's going to help them take care of their blood sugars, that's going to may potentially make it challenging. And back to culture, do they value these recommended changes? Here in Sacramento, we have a very large Eastern European Pentecostal population, and we tend to see a very high no-show rate in our gestational diabetes appointments, because there seems to be a feeling that this is not a problem. Big babies are healthy babies, and diabetes is not going to be something that's going to really make a difference, and whether they really value that this is going to make a difference in their baby's outcome. So I want to shift a little bit over to perinatal mood disorder and anxiety disorder. And I'm hoping most of you have seen that we have shifted over from postpartum depression to perinatal mood disorder. And again, perinatal implies around the birth, that we see depression not only postpartum but before pregnancy, as well as during pregnancy. Anxiety disorder as well. These are just different symptoms, but equally debilitating. This can be one of the most common complications during and after pregnancy. 14 to 25% of pregnant women meet criteria for clinical depression. And as we know, depression will double with increased stress, and gestational diabetes can be a potential stressor. So with the criteria for clinical depression is, are they having the following symptoms every day for 2 weeks or more? And again, these symptoms can sometimes be difficult to tease out from baby blues and from common pregnancy symptoms, that persistent gloominess, difficulty sleeping or sleeping too much. Even though they're getting a good night's sleep, do they still feel tired in the morning? Anhedonia, do they feel that things that they used to make them happy, like their children, don't make them happy anymore? They're just not happy. Is their appetite changed? Are they eating too much or not eating enough? Again, this is going to directly impact their diabetes care. Carbohydrates can definitely elevate one's mood if they're feeling sad. If you're having a patient with binge eating issues, just to elevate her mood temporarily, we know that this can obviously be problematic for her blood sugar control. Suicidal thoughts, plans, or intentions definitely always need to be assessed, and this is difficult for some providers because if she says yes, what do you do? It's really important to have the resources available, but this is not necessarily required to meet criteria for depression. This is something you're going to see for more severe symptoms. In contrast, anxiety, as I said, just is debilitating, just different symptoms. Again, these symptoms occur every day, all day for 2 weeks or more. Excessive worry, anxiety, they're constantly tense. Intrusive thoughts of something wrong with the baby's health. Again, you will see this differentiate between pregnancy and postpartum. The thoughts during pregnancy are, is my baby moving? I haven't felt my baby move in a while. My blood sugars were high. Is something going wrong with my baby? To postpartum, I can't sleep because I'm afraid my baby might stop breathing. These feelings of reoccurring fears of thoughts can cause irritability and restlessness. You may see a higher level of vigilance with these pregnancies, which is actually can cause more stress, higher blood sugars. A good rule of thumb for both depression and anxiety is if you're finding that these symptoms interfere with their daily activities like eating, sleeping, relationships, then it's really time to seek out treatment. And we're going to talk about that right now, or actually after we talk about this slide. The Edinburgh Postnatal Depression Scale. Actually, I think that is, Cynthia, my next question. Could you ask that?
Okay, now our next question. Is it part of your standard of care to assess all women for perinatal mood and anxiety disorders? Yes, no, and not applicable. Okay, 63% said yes, it is part of their standard to assess everybody. 22% said no, and 15% said it was not applicable.
Thank you.
And the next question is, what assessments or screening tools do you use with your clients? Choices are your CDAP stress check, an Edinburgh depression scale, some other tool, nothing, or not applicable. Okay, 2% are using the stress check, 48% are using the Edinburgh depression scale, 20% are using another tool, 10% are using anything, and 19% said it's not applicable.
Thank you, Cynthia. So I'm glad to hear that the majority of you are using the Edinburgh Depression Scale because I really like this tool. I think it's really easy to administer. It's not very long. It's low literacy, especially when you're in crisis. This is something you don't want to give a questionnaire or a screening tool that's too difficult to understand. This is valid or a valid tool to use during and after pregnancy and actually can measure anxiety. There are about 2 to 3 questions that address anxiety-related symptoms. I like it. It's not a diagnostic tool. You can't diagnose off of this, but some insurances you can bill using the Edinburgh, which a lot of people appreciate. And I think it really helps if you do not have a social worker or access to a psychosocial provider in your office. This is a great tool to be administered. When in doubt, though, always use your clinical judgment. Even if the Edinburgh says something else or your other questionnaire says something different, always to engage. What is her affect like? Is she engaging with you? Is she having any eye contact with you? What's her tone of her speech? Just basically, how are you feeling today and how are things going? Always refer when in doubt because it doesn't hurt to refer, even if because the problem is a lot of these women who are experiencing moderate to severe symptoms will probably not follow up. So it is really important to be assessing at each visit, how are you doing today? we talked about going to counseling last week. How did that go? Were you able to access it, or were there some barriers to seeking treatment? And always evaluate the risk levels. This is, I know, a big liability for us. We want to make sure that this is important and documented at each visit. So let's switch over to treatment options, and Cynthia does have a question for you.
What resources do you have available for your clients? Psychiatrist, general counseling, support groups, other, not applicable. So 10% have access to a psychiatrist, 46% to counseling, 12% to support groups, 20% to another form of support, and 12% said it is not applicable.
Okay, very good. Thank you. Medication, and I'm glad some of you have access to psychiatry. I know some OBs don't feel comfortable in prescribing medications, but medication is actually recommended for more moderate to severe symptoms of depression and anxiety. This is something difficult. Obviously, you always want to weigh the pros and cons, the risks and benefits of medication during pregnancy, especially at what trimester they are. But obviously, women who are suffering from bipolar or severe depression and anxiety, this will definitely interfere with their ability to self-manage their diabetes. So this is obviously something that needs to be taken seriously or into consideration. Psychotherapy, specifically cognitive behavior therapy, which is restructuring how one thinks to have different emotional and behavior reactions, and interpersonal psychotherapy, which addresses how the role that addresses the role that dysfunctional relationships play in the patient's depression and anxiety, are very effective for low to moderate symptoms of depression and anxiety. Support groups, I think, are very helpful because it helps reduce feelings of isolation, offers problem-solving ideas, opportunities to discuss fears and frustrations, and is validating. This is both effective during and after pregnancy. In fact, we have a pregnancy centering program in our Sweet Success clinic at Sutter, where we do a lot of support groups, or we do the education within a support setting, and this seems to offer a lot, not only problem-solving ideas for diabetes management, but how to cope with the diabetes itself. Alternative treatments, there is research that says that supports that exercise, low to moderate exercise, vitamin D, we're hearing a lot about the sunshine vitamin, getting enough vitamin D, and acupuncture are also very effective. Acupuncture actually is supposed to be almost as efficacious as cognitive behavior therapy. But again, I would not recommend these as monotherapies, more as something to support psychotherapy if she's dealing with anxiety and depression. However, if you're dealing with more severe symptoms like psychosis, bipolar, I would definitely defer to a psychiatrist in this field. So let's go, and I'm sorry, let's go back to that one more time. I'm not going to review this postpartum because I think this is something that we're always assessing both between pregnancies, during pregnancies, and after. This is something that I think should be not just left as the topic of their last appointment before they deliver their babies, but something addressed throughout the pregnancy and postpartum period. Because if it is a concern, you really want to have a treatment plan developed with the patient and her provider so that we're not dealing with a crisis and having limited options, treatment options, when she is in crisis with a baby.